Welcome to Distance is No Obstacle, a medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia.
Welcome to this episode of the Distance is No Obstacle podcast, Eye Health in Rural WA. I'm Byron, Klein, optometrist and at Headland Eye Care in Port Hedland. And joining me is fellow optometrist Alex Craig from Karratha Eye Care. Welcome, Alex.
Thanks, Byron.
So today we're talking about the joys and challenges of providing comprehensive eye care in regional and remote locations, as well as the telehealth model through Lines Outback Vision. So we hope to share some tips and resources that will be highly relevant to you, a rural health professional, that will assist in providing your community with optimal eye care. So to begin with, Alex, do you mind just introducing yourself and telling us your story at Karratha Eye Care and what you do?
Yeah, absolutely. So like Byron said, my name's Alex Craig. I own a private practice in Karratha. I've been in Karratha for 10 years. My journey started out working for corporate optometry through OPSM for the first 4 years of my time in Karratha. Corporate optometry has its place and does some really, really good work, but it tends to be a little bit less flexible. And in regional Australia, and it's no different in regional Western Australia, medical services or the delivery of healthcare services needs to be flexible in order to typically capture people appropriately, or when we see them. People tend to drive really long distances to see us, and so trying to get as much done in the one visit as possible is typically what we try to do, and this just wasn't possible in the confines of corporate optometry. In 2019, I left OPSM and I opened Karratha Eye Care as a way to try to engage with the community, as a way to try to engage with WACHS and with the public healthcare system, as well as with the WACHS, to provide better accessibility to chronic disease management and better accessibility to eye care or primary eye care in general. We are now in our 6th year and have been able to work really well with other entities like Headland Eye Care, as well as with Lines Outback Vision, in really stabilizing how chronic disease management or how eye care is managed in regional Australia. We've been able to create novel pathways through telehealth, telehealth service delivery, increasing opportunities for our patients to be seen, and ensuring that they don't have to or aren't saddled necessarily with the burden of having to travel to Perth as much, which has been good. We obviously endeavour to work with all other allied health professionals, specifically with GPs, as well as with medical personnel from public hospital systems. So that's my story. We are continuing to work to see how we can improve accessibility, specifically in the WACHS this year, to see how we can.
So do you mind just saying what WACHS are?
Yes, Aboriginal controlled health services or health organisations, similar, also known as Aboriginal Medical Services. In Karratha, we have one in Roban, and we have one in Port Hedland as well. So we have Werrikimaya in Port Hedland, and we have Marmara in Roban. And so a lot of the work that we do, a lot of the research that we've been able to publish suggests that if we can improve the overall number of times that a patient is able to be seen, but more importantly, if we can improve the overall number of things that can be done in a single appointment, we end up with far better outcomes. So this is where telehealth really comes in, and the data that surrounds telehealth is really encouraging, especially when we talk about patients who require chronic disease management.
For sure. I guess we'll touch on that a bit later about telehealth and the power of telehealth, especially in these kinds of locations. Cool. Alrighty. So before we press on, my name's Byron. A very similar story to Alex. We're about a year and a half behind Alex starting Karratha Eye Care. So we started and we're coming into our 5th year now, and probably share a lot of similar ideas as to Alex at Karratha Eye Care. So, and also Alex shows a lot of leadership in that space, and we support one another in trying to provide the best eye care we can. So I haven't got much more to add to what Alex has said on that intro, but Alex, do you mind talking a bit about, I guess, more on what difficulties or challenges and also the joys of providing eye care in a regional and remote location. And yeah, what things you've done to provide better patient care and outcomes, especially when it comes to being involved in community and knowing, you know, who is working, what other resources you have available to you, whether it be, you know, GPs or pharmacists or nurses. Yeah, do you mind sharing a bit on that?
Yeah, absolutely. So I think my passion comes from really championing appropriate referral pathways. And I think that in regional Australia, it's not that easy, primarily because we don't typically have as many service providers. So I think it's really important to, and the thing that you mentioned around community, I think is something that we really want to highlight. I think it's really important to try to develop a community of practitioners in regional Australia or in your town, people that you know that you can sort of work with and do a lot of co-management with. We've tried to spend a lot of time doing work with local GPs. We, you know, give presentations to pharmacists and pharmacy students every year. We engage with UWA Regional Medical School to try to, from a grassroots level, try to encourage medical students and junior doctors to engage in collaborative care and to engage in collaborative care lines of thinking, to really sort of present optometry and to present what we're able to do as optometrists as valuable for them as a way to actually improve their overall ability to manage their own patients. And so that aspect of how we practice, I think, is unique to regional Australia. I think in the city, I think it's very easy to move patients through either public or private medical systems as a result of having existing infrastructure. I think that one of our biggest challenges that we found or that we faced, especially when opening up a private practice, was that there wasn't a lot of infrastructure, and still to this day isn't a lot of infrastructure available. It comes down to how much I know and whom I know, which is interesting but also frustrating. And I think this is also something that gives us a bit of a platform from an advocacy point of view when we talk to federal and state governments around policy and policy change, to really reinforce the fact that there are people in regional Australia that are actually working to try to improve the overall accessibility to all different types of services, not just eye care. And these pathways need to be cemented in so that it's not reliant on the individual practitioners, because that's ultimately what we've seen in the past. Is that we've seen there's a couple of people who wanted to make change, but because it was very hard to get policy changed, they either end up burning out or moving on. And so that's really sort of the second piece to it. One is understanding who's who. So one's understanding how does the patient move from GP all the way through to tertiary care, and what kind of a role do you play as a primary eye care provider, or as a primary allied health provider, and I guess the third piece that sort of links into that is then going to be communication. So we've made a really strong concerted effort to write a lot of letters to GPs, even in patients that are well. If there is something that is that we think that would be interesting for the GPs, or even just a form of communication around, hey, your patient's fine, everything's going really well, I think really just solidifies relationships, and that's really obviously something that we're trying to champion. We're trying to build that level of trust, I guess, between primary care, so patients don't end up sitting. Because what ends up happening is that when that doesn't exist, patients end up sitting on what they call the wait for the wait list, which is essentially just a wait list that is waiting to be triaged. And in some places, and I saw data last night that has come out of Adelaide, where in one hospital in Adelaide, the wait list is over 60 months, over 5 years, to be triaged. So this is not to be seen, this is to be triaged, and this is in Adelaide. And so you can imagine then that where we have places where we have less serviceability, that the problem might be compounded. And so this is really why we wanted to take on things like telehealth. The complexities of the system, though, don't get us down, and I think that's really important as well. I think that we're not as KPI bound as corporate optometry would be, and I think as a result that then gives us an opportunity to really find joy in the process. It can be frustrating, but at the same time we're able to completely manage our patients from go to woe, and I think there's some sort of professional satisfaction in that. Also, we're practicing at the edge of our profession, so we're able to push the limitations. And there's a lot of watch this space stuff happening at the moment. We have a lot of lobby work going on to try to get orals for optometry around certain medications, antibiotics, etc. Just so that our ability to manage patients, especially in regional Australia, is a little bit larger than what it is now, and patients don't have to sit and wait for GPs for 4 to 6 weeks. And so we're really trying to aim to figure out how can we make the optometrist the GP for the eye? How can we make them integral to management of chronic disease? Primarily because the retina is obviously one of the places where we can see microvasculature and pick up on systemic change as well. So there's a lot of joys in the complications, I think. And I think a lot of that comes down to really just being able to practice as full scope as we can, and to be and feel like an active part of my community. I often said that I want to be able to go to the pub and be able to look around and not feel like I've shortchanged anyone as a result of my working environment. And that's not to say that that's a direct correlation or a direct result of corporate optometry, but I think that we have far better opportunities to invest in people, to invest in our to invest in our communities, to invest in culture, and to provide eye care that's tailored to the region, to save people money, and to really build a strong medical community as a result.
No, definitely. And echo everything you said. I was just going to give Rural Health West a little plug there as well. Like, I think we're quite fortunate to have some of the the Pilbara Health Professional Network, and each region has that. And I'd encourage anyone who's listening and is a health practitioner or involved in health to get involved in those meetings. They take a little bit of energy sometimes. If you're introverted, they're definitely worthwhile going to, because often these locations are transient, and healthcare providers can change on a monthly basis. So it's nice to connect with people and put a face to their name. So you can, when you're writing to them, you can you know who you're talking to. So I think just want to say it's really, I think, a great system of connecting people together and working together to get better outcomes for people. And so flowing on from that, I guess, Alex, so you're talking about cementing better pathways and improving I guess collaborative care models. So Lions Outback Vision is a not-for-profit organisation that provide eye care services through ophthalmology and optometry, and as well as GPs and other health providers. Do you mind talking a bit about telehealth and model, and how Karratha Eye Care works? Because I know you've got quite a unique situation where you're providing telehealth clinics for Lions Outback Vision out of your own private clinic. Going back to that 5-year triage of the Adelaide Hospital, can you talk more to what this model has done for wait times in Karratha, and how's it sped things up or got people to be seen when they need to be seen? How does that work?
Yeah, so the data coming out of the Pilbara in our most recent articles would suggest that we are able to, we have one of the places in Western Australia that has the least number of ophthalmological service provision. So we have one of the lowest number of hospital days, yet we also have the lowest waitlist, or the shortest waitlist time. And a lot of the research that we would actually attribute that to is it would be purely around the fact that we are deputizing optometry by telehealth. So something simple like this works. GP thinks that a patient maybe has a cataract. Patient is referred into optometry. We see that patient, we do comprehensive eye care. And there's a point here that needs to be made around disease-specific eye care and comprehensive eye care. I think that in previous models of these iterations of telehealth, or these iterations of referrals into public health system, when you refer for something in specific, they go into a specific clinic, and so we're often then not doing comprehensive eye checking as a result of receiving a referral from GPs or from other allied health professionals. So that's the first point in how this model has changed. And ultimately, what that means is it means that from an optometry point of view, from an eye care primary healthcare point of view, we're also then reassessing that patient, primarily because a lot of GPs or other allied health professionals don't have the opportunity to be able to do that in their own rooms. So that patient's getting a getting a comprehensive eye check, as well as then a secondary opinion on what the lens looks like. So say if it's for cataract, then patients found to have cataract, they're found to have visually significant cataract. Now, that this is again differs between private and public surgery. It differs between state to state. It differs between regions, and all these definitions are available online at your local state-wide health websites. So often this is based on what they call best corrected visual acuity, and very typically it's going to be limited to the driving standard, which would be 6 on 12. The other things that come into this is going to be activities of daily living, risk for trips and falls, quality of life, etc. And the third category would be then risk of one eye versus 2 eyes, and ultimate visual prognosis. Regardless, the patient then is found to have cataract. We then can do one of two things. So then if we have the time in that consultation, we can do an ad hoc telehealth. So basically meaning that there is an on-call telehealth specialist. So there's an ophthalmologist, either a registrar or a consultant, who is available from 9 to 5, Monday to Friday.
That's pretty unique. I don't know of are there any other states in Australia that you know of that have this service available to them?
No, this is absolutely unique to WA, and it's obviously been something that we've built over the last 10 years. And really the goal is to try to triage, to be able to have primary care opinions, triage, discuss, consent, and waitlist, all within a very typical sort of 30-minute consultation. And so that would be the first iteration, is what they call ad hoc. Ad hoc, then I would reach out to Lions Outback Vision. Hey, is somebody available for a chat about a cataract surgery? Within a minute, the guy who's on call will message back, yep, available. Can you give me some details? So then we start the call, and I pitch it like a mini grand round. So I introduce the patient to the ophthalmologist. So now we have a 3-way conversation. We found this to be absolutely necessary, in that the patient is now involved in their own care with the specialist and their primary care provider. So we find this not only to be empowering from an educational point of view, but we often now find that our attendance rate, so our patients showing up for surgeries, as well as compliance with medication after surgeries, is significantly improved as a result. Patients are then able to discuss the surgery, any of their worries, any of their fears, any of their queries around outcomes with the specialist live. And then as a result, then the patient is able to be consented, so risks are explained, and the patient is automatically then waitlisted. So this is removed what normally would be a 3 to 6 month wait on a wait list before you even get in to see the patient. So this is the reason why we're able to streamline and fast track this service. Additionally, then we've added in other equipment that's required for these surgeries. So we're able to measure the length of the eye. We're able to take pictures with optical coherence tomography, which works very much like a CT scan, or we would call it the ultrasound of the eye. Gives us a 3D in-depth scan of the retina. This is really helpful in not only management of cataract, but management of all other types of macular disease, specifically diseases like diabetes and macular degeneration and glaucoma. And all diseases that patients typically would have had to have got on a plane and fly to Perth for, and sometimes at their own cost. So that's the first iteration. The second iteration, like Byron had mentioned, is what's called a booked-in telehealth. So from around the region, we would have people referring in, sometimes from public hospitals, sometimes from local GPs, sometimes from other optometrists, and refer into Lions Outback Vision. Those referrals would be triaged, and then we would run a clinic for them. In the first early days, we ran that in the hospital system. However, we found that there was limitations around image sharing that caused that system to not be as efficient as it possibly could. So we moved that into the private clinic, and we ran it as a private public model. So patients were not charged. They were billed Medicare, or they were bulk billed. However, they still got accessibility to the specialists within 30 days of their referral. We found that 85% of these referrals with one touch point to ophthalmology could be discharged back into optometry care for up to 3 to 5 years, depending on the case. Patients that didn't require referral back to optometry or back into primary care were then ultimately put into a surgical list or in for a tertiary examination, either on the Outback Vision van that would come through, or in an in-person clinic that now runs monthly. So those two different iterations of the telehealth service have saved patients thousands of dollars, have saved the PAT system thousands of dollars, have allowed for patients, even patients with chronic disease management, to remain in Karratha and not have to travel so far for specialty follow-ups. And primarily because we're able now to share images at such a high level, and we're able to use platforms like Harmony which allows for us, it's a novel concept that's come through from TopCon Australia, which allows for us to instantly share the entire imaging file. And I say that because the difference was we were only able to share a screenshot, but we're able to share the entire imaging file with the surgeon or with the specialist instantaneously. And this makes a very, very big difference to how long patients remain in the region or how long patients are on the wait list.
That's news to me. I didn't realize that 80% of the people you saw didn't need to see an ophthalmologist afterwards. So that's
not after one, not after the initial. And again, this speaks to our first point around creating the appropriateness of referral pathway. So the more education that we put into our GPs, the more education we put into our allied health professionals, the different or the quality or the different type of referrals that we tend to see, right? And we certainly have seen that then over the years as well. That by providing this kind of a service, we don't get as many referrals that are mismatched ultimately to the outcome at the end. Yeah.
I think that's fantastic. And I knew it was efficient, but I hadn't heard that number. I know you've probably seen hundreds to thousands of people almost probably approaching through this model. So that's really cool, because I thought it also highlights that, possibly the inefficiency of that tertiary hospital in Adelaide. They're swamped with referrals, and not saying that they're inappropriate referrals, but maybe they could have been optimized and it might not be as a significant backlog like there is now. So I know actually, speaking of Adelaide, there was an optometrist, I think Jackie Warren, she was employed as a pilot study as an optometrist in a hospital, which again I think was highly efficient in getting people seen faster and getting the care they needed. So that's really great to hear. One day maybe I'll get a biometer in my rooms too, but at this point,
I think ultimately there needs to be a balance between proactivity and productivity as well. It's no secret that these types of clinics should probably belong in the public sector, and that optometry is really fighting for a position in the public sector, especially in hospitals, especially in major cities like Adelaide and Perth, where we have burgeoning wait lists, and the burden of unavoidable blindness is sort of very, very appropriate. So we do know that this system works. We know that it's worked really, really, really well in regional Australia, and I guess the call is to then try to do something about it in the larger subsectors of urban developed areas.
Yeah, definitely, because I imagine as well, that service you're providing probably isn't very efficient business model for you. So that's the next step, right? But that's a credit to you for taking it on and then doing it. Yeah. Terrific. So I guess going on from that, do you have any other tidbits of eye care in regional places, and how any other allied health or medical health practitioners can support their patients with better eye care?
Yeah, look, I think ultimately it just comes back to what we talked about at the start, which is community. I think that we've all picked to practice in a regional location as a result of our desire to want to see an improvement in service delivery. We understand that the demographic is wide and varied. We understand that the rates of disease and the intervention times are significantly skewed as a result of people's desire to want to live regionally. And I think, for me specifically, and now that links back into why we keep doing what we're doing, is that I don't think that it is necessarily fair that because we've chosen to live in regional Australia that we have a disadvantaged access to medical care. And so I think if we're all sort of thinking that, and we all sort of believe that, and that's the reason why we've maintained our positions in the region, I think really just spending time utilizing efforts like Rural Health West, and looking at the PHPNs and the professional nights, and KDCCI and business breakfasts and things like that, to really just become plugged into your community, I think would be my biggest advice. I really want to champion relational eye care, or relational co-management. I think for far too long there's too many barriers up between where people actually fit, and I think that we're just not asking the right questions maybe. And in regional Australia, I think those opportunities are necessary. They're available and they're necessary, I think, for our patients to ultimately achieve best outcomes.
Definitely. Cool. Yeah, I guess I'd add to that, just encourage any young people who've just graduated to go remote or regional and have a go, so to speak, and put yourself out of your comfort zone, because I think not only is it rewarding for your career and you learn a lot in these kinds of settings, but they're great places to live. Like, as a rule of thumb, regional Australia is great, so we need more good people who are willing to go to these kinds of places and provide good care, because I think that's another barrier, is getting quality and even just the volume of people to be here, number one, and two, not stay on for longer than a year or two, because I think continuity of care is another important aspect, especially in the regional place, that, like, especially in mining towns like Karratha and Headlam, where it's quite transient.
Yeah, absolutely. Yeah, and I think that's also done by the incumbent practitioners investing in education systems. I mean, you and me and both, and Lions Outback Vision all invest in UWA and UWA eye care and optometry, and champion new programs that allow for better access to more practitioners that may be interested in coming and working in regional Australia. But I also think that there needs to be an emphasis on systematic change, and that's often the discomfort, I think, is trying to figure out, how do we ensure that this outlives us? How do we ensure that these systems are available for the next generation of eye care, or the next generation of general health practitioners as well? So, yeah,
definitely. Well, it's been great speaking with you, Alex, and I hope anyone listening to this podcast has learned a few things and taken some takeaways. But I guess any final thoughts or things you wanted to say?
Look, I had maybe some thoughts on going through specific conditions, but I think that that's probably out of the scope of this podcast. I think that if you are interested in working with optometry, or you are interested in doing more through collaborative care and co-management, and we have opportunities to do co-management with so many people. Like, we have patients that are at risk of falls. We have patients who have low vision. This ties into social work. It ties into physiotherapy. It ties into even speech pathology and pediatrics, and a lot of these patients we're all seeing together, and so there certainly are options to share information, to share thought processes, to work together collaboratively, not just on a professional level but also on a social level, to really work together to raise the level of care that we're able to give to all of our patients as a result of our desire and their desire to want to live and thrive in a regional location.
Sure. No, I agree. Awesome. We'll catch up with you soon, eh?
Yeah, we'll meet halfway at Wind Creek.
That's good. Cheers.
Thanks, Byron.